Okay, next case. No headlines on this one. We'll make you figure out what joint it is, what organ it is. 35-year-old female patient has had joint pains for 1 year. Sounds like a joint question. Okay? Joint pains for 1 year. If this was CCS, this is probably not an acute emergent problem. Pause me, then play me. 35-year-old female patient has had joint pains for 1 year. Pain began in her right knee, left elbow, and right wrist. So I want to get a mental right knee, left elbow, right wrist. It's not all in one place, and it sounds asymmetric so far. And now has become bilateral in these joints. Okay, so now we have bilateral, symmetric, multiple joint involvement, and involves all the MCP joints. Now that already is giving me a lot of information. I've now gone from a list that's this long in the differential diagnosis of joint pains in a 35-year-old woman to a list that's about this long. Okay? MCPs, what joints is that? Wrists, MCP, metacarpal phalangeal, PIP, proximal interphalangeal, DIPs, distal interphalangeals. Now I got all 10 MCPs involved. Symmetric. You know how many joints are involved I just described? 10 joints right there in my hands. We do a joint count. Each little knuckle counts for a joint. And it's symmetric in both hands. Bilateral, symmetric hand involvement in a 35-year-old woman. What should be number one at the list right now, already? And you're going to have to fight it out of the list. What is it? Rheumatoid arthritis. Right age, right gender, right joints, right symmetry. No rashes, no hair loss, or back pain. What I care about rashes? Oh, okay, so 35-year-old woman, joint pain, maybe I would think lupus. I didn't really think it anyway. Hair loss, lupus, didn't think it anyway. Back pain. RA, very interestingly, rheumatoid arthritis, RA, does not usually involve back involvement, meaning the spinal vertebral column, except for the atlantoaxial C1, C2 vertebral bodies. Otherwise, the back, interestingly enough, is spared in rheumatoid arthritis. How would I remember that? I just thought of a mnemonic. I just told you this is bilateral and symmetric. We all got one spine. You can't have two spines and symmetrical spine involvement. Think that way. Spine is not involved, again, except for C1, C2. Morning stiffness is present for approximately 1 hour. Is morning stiffness characteristic or not characteristic of rheumatoid arthritis? It's extremely characteristic in rheumatoid arthritis. Generalized fatigue, anorexia, and weakness are also present. Sounds like constitutional symptoms. Broad, generalized inflammatory symptoms. No history of fever, weight loss, or diarrhea. Why would they even tell me about diarrhea? Well, diarrhea, joint pains, going on for a year. Could there be some chronic inflammatory bowel disease and chronic joint disease? Yeah, Crohn's disease, ulcerative colitis. Do I hear anything about diarrhea? Yeah, I heard that she doesn't have it. Okay? So right now, my choices are rheumatoid arthritis as number 1 through 5. Physical exam, 37 degrees. I'm not even giving any additional vital signs. If this was a CCS question, I'll tell you 37 degrees, 120/80, heart rate 76, respiratory rate 14. Obviously, a joint problem that's going on for a year is chronic and is a stable problem. There's active bilateral synovitis, which consists of warmth, swelling, and tenderness of the knees, which are now bilateral, wrists and elbows, MCPs and PIPs, and ankles, both ankles. Distal interphalangeal joints are normal. Isn't that peculiar? Wrists, that's 2. 10 MCPs is 22. No, 2. 10 is 12. 22 joints in the hands, but yet the DIPs are all miraculously spared. Is there something peculiar about that? No. That's how rheumatoid arthritis is distributed in the hand. DIPs are spared. And in fact, if the DIP joints are involved, it makes me think of something other than rheumatoid arthritis. So unlikely is it that RA has DIP involvement. A related disease that does cause this distribution of joint findings and does involve these DIPs is what? Destructive inflammatory arthritis? Psoriatic arthritis. Prominent DIP involvement. Not in rheumatoid arthritis, though. Okay? She has flexion contracture of the right elbow. There's decreased grip strength bilaterally. No hair loss, no oral ulcers. Again, something that I might see in lupus. No rash, something I would see in lupus. Lungs are clear, no murmurs, rubs, or gallops. Abdomen, no hepatosplenomegaly. And right now, my differential diagnosis is very short. It's really limited to rheumatoid arthritis. Single best answer, they might list you 5 or 6 choices. Obvious rheumatoid arthritis, don't spend time thinking about the others. All right? Actually, on USMLE released CCS cases, I believe there is a case of rheumatoid arthritis. And they let you take care of the patient for several months. I felt great. I made the diagnosis with the history. I did the appropriate diagnostic test, which we'll talk about. I treated the patient with the right drugs, and the patient kept coming back. The question just wouldn't end. And I kept treating the patient with certain drugs. The patient kept being there. They wouldn't let me finish the case. Until finally I treated her one last time with exactly the same thing, and she finally got better, and they said, thank you, end of case. All right? So rheumatoid arthritis, again, a chronic, stable disease, something that can go on for a long time, and not one of those emergent acute diseases I got to rush and put in IVs or start intravenous medications, etc. We talked about what is consistent about rheumatoid arthritis in this patient. What is in this question that might make me think of lupus, and what is not consistent with lupus? Why am I so confident of my diagnosis of RA purely based on my history and physical exam? Well, lupus, is she the right age and gender? Absolutely. Middle-aged women, or even younger than middle-aged. 35, even 20s, 30s, 40s. Above that, it's atypical to have lupus come on older than that age group. Is there a racial difference? Blacks more commonly than whites in lupus? Yes, much more common in blacks than in whites. Can white women get it? Yes. Can black men get it? Yes. Can white men get it? Now we're really getting into less and less likely subsets. A black woman, certainly the most common demographic group in the United States to have lupus. And not a rare disease. What would I like to hear in this patient case description to make me think lupus? Well, a lot of things that we're told she doesn't have. She has no alopecia. She has no malar rash in the butterfly distribution in the cheekbone area. She doesn't have that. She doesn't have oral aphthous ulcers. All right? She doesn't have discoid lupus, which means disc-shaped red lesions typically on the face. She doesn't have photosensitivity. I don't hear that she goes out, sits in the sun, and comes back and is red from head to toe. All right? Or I shouldn't say red from head to toe. I should say in the areas that are light exposed. What else would I see? Lupus in the heart, maybe a pericardial effusion, maybe a pleural effusion. Does it have to be? Do I need to have all of these for lupus? No. I want to see a bunch of them at least. Now, for the boards, you don't have to remember the American Rheumatologic Association lists. You need to have, 7 out of 11 criteria for lupus, or 4 out of 7, or 4 out of 11 for rheumatoid arthritis. Forget that. It'll be a clinical picture that's characteristic. Don't start checking off in your mind if they have enough criteria. All right? This patient clearly has rheumatoid arthritis and not lupus. We said in lupus, let's get back to lupus, pericarditis, pleuritis, major organ involvement between here and here, kidneys. All right? Lupus nephritis, which takes the form of glomerulonephritis, with proteinuria, red blood cell casts, suggests glomerulonephritis. What else in lupus? Well, in this general region, GYN area, is there any involvement in lupus? Yes, a woman who's in her childbearing years. What am I worried about? Recurrent second trimester miscarriages. All right? Any woman who's had a miscarriage in her second trimester, even on her first pregnancy, think about lupus. All right? If it's happened more than once, it's lupus until proven otherwise. Or if not lupus, at least something that is related to lupus, and that is the antiphospholipid syndrome, which is a hypercoagulable state in women. Do all those women have lupus? No. And that's why the older name for this syndrome of the lupus anticoagulant is a bad name for this syndrome. Not everyone with antiphospholipid syndrome has lupus. And in fact, the antiphospholipid syndrome is not one where you look like you're anticoagulated. It's not really a lupus anticoagulant. It's really a hypercoagulable state. So antiphospholipid syndrome is a hypercoagulable state, sometimes seen in patients with lupus. What else might I see? In the joints, there can be arthralgias diffusely, not necessarily bilateral. And furthermore, it is not usually an arthritis. It is much more of an arthralgia picture with joint aches without objective signs and symptoms of swelling. How about blood test abnormalities? Well, we haven't gotten to labs yet for rheumatoid arthritis, but let's just talk briefly about what you would expect to see in lupus. On the CBC, basically each of the three major cell lines can be affected in lupus. In lupus, you might see an anemia, red blood cell. Anemia from what? Anemia of chronic disease. How about the white blood cell count? Can that be affected or influenced by lupus? Yes. Most lupus patients, or many, are leukopenic. All right? You would say, wow, look at all this inflammation going on in this patient. Joints, mouth, lungs, heart, kidneys. I'd expect a white count that's high. In lupus, strangely enough, the white blood cell count is low. All right? We mentioned anemia of chronic disease. We should also mention autoimmune, hemolytic anemia in lupus. Again, it's a very autoimmune process, and not just autoimmune hemolytic anemia, but autoimmune thrombocytopenia. Immune thrombocytopenia, ITP, is seen often in patients with lupus. On the blood test and chemistries with lupus, what do I expect to see? I might see some signs of the glomerulonephritis, so creatinine elevation. Liver functions are usually well preserved and not affected by lupus. And what other serologies might be positive in lupus? The rheumatologic diseases, you should know for each disease which serological test is a helpful, positive test for you. And in lupus, there are several. One is the least specific, but most sensitive, anti-nuclear antibody, ANA, particularly with high levels. Much more specific is anti-double-stranded DNA. With patients who don't have lupus won't have that antibody, whereas many patients with various collagen vascular diseases have a positive ANA. There's one particular form of lupus in which the serology I'll check is an anti-histone antibody. What form of lupus is that? Drug-induced. And the drugs that do that are typically drugs like hydralazine, procainamide, isoniazid. And those patients, they don't get this whole full-blown lupus syndrome I just described. They typically get fevers, arthralgias, pleuritis, and pericarditis. They don't get the major CNS involvement, which I failed to mention, which I'll come back to in a moment in lupus. They don't get the nephritis. They don't get the autoimmune hemolytic anemias. But they do have the fevers, joint aches, pleuritis, pericarditis. The treatment is to stop the offending drug, treat with NSAIDs until the patient feels better, and they will get better. CNS involvement in lupus, very important. Can present with change in mental status, with cognitive defects, even to the point of dementia. It can present with cerebral involvement in lupus, can present with neuropsychiatric symptoms, depression, and not just depression because they're sick, but a depression as a primary cerebral manifestation of lupus. And lastly, seizure disorder in a patient with lupus. Patients can also present with psychosis as a neuropsychiatric manifestation. Again, that's part of SLE, systemic lupus erythematosus, not part of the drug-induced lupus. Now, osteoarthritis. Out of this whole list here, by far, by factor of 50 to 1 or 100 to 1, by far the most common is osteoarthritis, which is also known as DJD, degenerative joint disease, which helps me remember who gets it and where they get it. It's basically a degenerative joint disease. Your joints degenerate because they're overused. Which joints are overused? And most of us in 21st century society, well, we're working with our hands, so hands are often involved. And there the DIPs and PIPs are often involved. And you get Bouchard and Heberden's nodes. What other joints are involved? Well, we're walking around all day. Where do we bear our weight? On our hips and our knees. All right? And that's another common place of arthritis. If for some reason I have a particular activity, let's say I'm a carpenter and I'm banging nails all day, I'll have maybe wrist, maybe elbow, maybe shoulder. If I'm golfing all day, I have nothing better to do than to golf all day, I could have shoulder, I could have wrist, I could even have waist if I'm twisting a lot. There's not waist, but hips. There's a lot of use that's specific to various occupations, and the occupation will be the clue as to why someone is getting a particular joint involved. For instance, ballet dancers at the age of 23 might have been dancing for 20 years already. All right? And they could be dancing 6 hours a day, and their wrists, unless they're dancing on their hands, it's not their wrists, their knees and their ankles look like 80-year-olds. Right? And a lot of these young incredibly athletic women have to retire from dancing at age 23 because of such severe osteoarthritis. Osteoarthritis is a degenerative joint disease. It's not an inflammatory disease. I don't get fevers. I don't get white blood cell count elevation. I don't get high sedimentation rates. I don't get high C-reactive protein in osteoarthritis. What I do get is a destruction of the joint space, chronic symptoms, and basically these patients are told to rest the joint, do some physical therapy in osteoarthritis to increase the muscle strength around that joint so they don't develop muscle wasting in that region as well. And the treatment for osteoarthritis is, besides the rest, icing, physical therapy when appropriate, the pharmacologic treatment is aspirin and NSAIDs, and never, ever prednisone. You see prednisone in a patient, even with the most severe osteoarthritis, wrong answer. Rarely will inject joints of osteoarthritis with a steroid. That's a local injection, and even that's not to be used very often, and definitely not systemic steroids. Gout's can it involve the hands? It can. It's not common. It might involve the hands. It might involve some MCP joints. By far more common, you'll see joints in the lower extremities involved by gout. The classic one, of course, is the first toe, the big toe and podagra. These patients will be hyperuricemic. It's typically an acute onset of profound, intense, excruciating pain. And you'll look at the patient, all they got, they're howling in pain. And all they got is one red toe. And that can be excruciating. Gout, of course, you'll put a needle in. You'll try and get out what kind of crystals? Uric acid, calcium, urate crystals. Will you hold them up to the light in a test tube and say these are calcium urate? No, you put them under a microscope, particular kind of microscope. I'll order a polarizing light microscopy examination of that arthrocentesis fluid in the patient with gout, and I'll see what kind of crystal? Negatively birefringent crystal. And if I see a birefringent crystal inside of a poly, that's ideal. That's the best evidence that you have that a patient has gout. That white blood cell, that neutrophil, is actually eating up that crystal. Okay? If I got the exact same clinical picture, and I get some fluid out, and I look under polarizing light microscopy, and I see rhomboidal, positively birefringent crystals, what is that? Pseudogout. All right? Looks like gout in terms of clinical presentation, the fact that there's crystals, but the crystal is different. From a practical point of view, the acute treatment for gout and pseudogout is the same. What is the acute treatment? The first-line therapy for gout and pseudogout is non-steroidal anti-inflammatory drugs. High doses of ibuprofen, naproxen, etc. It works so effectively that you could almost use it as a diagnostic test. If you give this patient in exquisite agony a single dose of high dose of ibuprofen, and 2 hours later they think it's the greatest drug they've ever seen, that's very suggestive of gout. Other monoarticular arthritis won't get that dramatically better, like a septic arthritis. Okay? Now, I'm not saying that you should treat all patients with a monoarticular arthritis by giving them an NSAID and just saying, hope you feel better. Remember, a monoarticular arthritis, the differential diagnosis between a crystalline arthritis, gout or pseudogout, the differential there is aseptic arthritis. In that case, either staphylococcal or gonococcal. And again, aseptic arthritis, that is an acute emergent joint. That joint, I'm not going to say, well, why don't you try Motrin or Advil or Nuprin, all the ibuprofen products, and come back in a day or two. There's not many things that I would think of in rheumatology that are real emergencies for CCS. A monoarticular arthritis is one of them, because you must immediately tap that joint. I mean tap, I don't mean knock on it. It's not percussive. Tap means an arthrocentesis. Get out some fluid, look at it for crystals, and look at it for a gram stain. If you see the crystals, great. Gout or pseudogout, give it NSAIDs. If you see white blood cells and organisms, then you have a diagnosis that you start treating for immediately with intravenous antibiotics for either staphylococcal or gonococcal arthritis. All right? Often as a monoarticular arthritis in infectious arthritis. Inflammatory bowel disease, lastly, by the time you have joint symptoms, and it can be a frank arthritis, not just arthralgias, in patients with Crohn's disease or ulcerative colitis, the Crohn's disease and ulcerative colitis bowel symptoms are evident, except in kids. Kids sometimes present with the extraintestinal manifestations of Crohn's or colitis well before the bowel symptoms. They might have weight loss, growth retardation, unexplained fevers, arthralgias, arthritis, uveitis, iritis, oral aphthous ulcers, all of the things you see with inflammatory bowel disease, except for the bowel disease. In kids, teenagers have a high suspicion for IBD with those situations. In adults, you're going to see the extraintestinal manifestations when the bowel disease is obvious. Their bloody diarrhea, their abdominal pain will be clearly evident. We don't have it in this 35-year-old. So again, getting back to our case, rheumatoid arthritis. How are we going to evaluate this patient? Well, an ANA, good screening test. If you're on a CCS, rheumatoid arthritis, again, is not going to be an emergent problem. You won't lose points by typing in, giving an anti-nuclear antibody, and they'll say the test will be available in 2 days. Now remember, in CCS, not only do you have to order things, you're told when those things will be available, and you've got to decide what to do with the patient. You can't wait for 2 days. If you're taking the exam on a Monday in the Sylvain Learning Center, you can't wait until Wednesday to get the ANA back. Everyone will have gone home. They'll have locked up the center. You have to move the clock. In the CCS, unlike real life, you can make time move. All right? I know you're all wishing this tape would move and be over with, but you got to sit and suffer through it. In CCS, you can make the clock jump. You can move the clock 2 days forward if you want to get that test result. That sounds like a great thing to do, move things along, get through the case quicker. But remember, you might pay a price for that. If you're telling a patient with acute pulmonary edema, I'd like to get a sputum culture on you. Might be appropriate. You might think the patient has pneumonia. And you say, let's wait 2 days for that test result. That means nothing has been done for that patient in the next 2 days. You've gone back to the on-call room, you've waited 2 days for the sputum culture to come back, and that patient lies in acute pulmonary edema untreated for 2 days. Remember that atypical feature of CCS. You have to know about moving the clock. Now, how do I use the clock in rheumatoid arthritis? Which comes to the whole point of why I keep stressing acute, emergent versus stable chronic. In a stable chronic situation, you don't have to constantly move something within an hour and do something and do something and do something. If the patient's not acutely ill, you won't hurt the patient by doing a little less at the beginning. Do an ANA, maybe do an X-ray as your next step, and wait for the results. You don't have to start intravenous treatment on this patient. You don't have to start the patient on hot, aggressive immunosuppressant drugs in a patient like this question. All right? So what will I do? A leisurely ANA, it's a fine test. Do I want to wait till I get that test result back before I order anything else? It's reasonable. At the same time, I might say, let me draw ANA, type in anti-nuclear antibody. They say, okay, the test will be ready in 2 days. What do you want to do next? You could jump ahead 2 days, see what it shows. Or you could say, you know what, why don't I also send you from my office to the radiologist, get some hand films. After all, you got a lot of hand involvement. Let's see if you have the characteristic X-ray findings of, which I skipped one other blood test, characteristic X-ray findings. I'm skipping a lot of blood tests. What are some of the other blood tests we could draw as we're drawing blood all at once now? All right, let's get that out of the way. We talked about serologies in lupus. What are the serologies in arthritis? And again, you wouldn't have lost points had you not done these tests. Rheumatoid factor and C-reactive protein are not cheap tests to do. And just gone for an X-ray and looked for the characteristic X-ray findings. If, at the other hand, you say, I'm sticking the patient, remember, there are many ways to do things correctly on CCS. All right? Many ways to do things wrong. But also, there's a lot of options to do things in CCS in a stable kind of chronic patient. I'll order blood. I'll get an ANA. I expect it to be positive. I get a rheumatoid factor. I expect it to be positive. It's, after all, positive IgM antibody. A C-reactive protein, which is basically just another test for generalized inflammation, just like the much cheaper SED rate. That will be elevated. The SED rate will be elevated. And I'll get all these back within a couple of days. Reasonable to wait for them to come back. If you said, first, let me get the ANA, I'll wait 2 days. If that's negative, then I'll do a rheumatoid factor. If that's extremely positive, I'll think about lupus. You wouldn't lose points because, again, we have a stable patient. CBC, again, I might see anemia of chronic disease while we're drawing bloods. Let's get them all off. CBC, I might see anemia, all right, as part of the anemia of chronic disease in rheumatoid arthritis. Sure enough, that's what I see, the normal chromic, normal cytic anemia. Chemistries, is there anything particular about chemistries that I would find in rheumatoid arthritis? Not really. Okay. Arthrocentesis, if there was a single hot joint that was more asymmetric than everything else, I might do an arthrocentesis in rheumatoid arthritis. But it is not one of the usual diagnostic tests we would do. If you did find a single asymmetric joint, or a joint that looks much more inflamed than any other, it is appropriate in RA to do an arthrocentesis. Why? Because any previously injured joint is at greater risk for an infection. And again, we said rheumatoid arthritis should be symmetric. If you have something that looks asymmetric, you should think about whether there is a superimposed infectious arthritis, and it's appropriate to do a arthrocentesis. In this patient, let's say if that was done, and it wouldn't be my first choice, and in fact, unless I'm told there's a specific effusion, I wouldn't rush to do an arthrocentesis. Negative for crystals, negative gram stain, cultures were negative. Finally, x-ray of the hand, which I could do on that very first day, and they show that there are bony erosions, and I'll tell you also some joint space narrowing at all the metacarpal phalangeal joints. Very suggestive in this clinical setting of rheumatoid arthritis. In the setting of a negative or a low titer of an ANA, a positive rheumatoid factor, which is a positive IgM antibody, which is directed against IgG, a high C-reactive protein or SED rate, that's really enough to make the diagnosis of rheumatoid arthritis. You're not going to need to do anything more invasive than that. You don't need to do bone biopsies. You don't need to do CAT scans. There's nothing terribly invasive that patients with rheumatoid arthritis have. Some of the patients with the worst rheumatoid arthritis have never had anything more invasive than an X-ray. All right? They haven't needed arthrocentesis. They haven't needed CAT scans. They haven't needed any bone scans. How do we treat this patient? Rheumatoid arthritis is one of those complex diseases that often end up in the office of a specialist, the rheumatologist. However, the chronic patient who is relatively stable, who's not having bad disease flares, can be very well managed by internists, family practitioners, and even by interns. All right? And that's why it could show up on step 3. You need to know the first, second-line treatment for rheumatoid arthritis. You don't need to know how to treat the refractory patient with crippling disease, but you need to know the basics. What are the basics? If a patient has a hot joint, and whatever disease it is, you want to rest that joint and ice that joint. First-line therapy of rheumatoid arthritis in terms of pharmacologic therapy is aspirin and NSAIDs. Okay? If aspirin and NSAIDs are insufficient, then the second-line therapy, which I think is appropriate for an intern to know, but certainly if glucocorticoids aren't working, the patient's going to see a rheumatologist, are steroids. All right? So you need to think about that any time you see a patient on the boards with rheumatoid arthritis, you have to think, excuse me, this patient with rheumatoid arthritis is almost synonymous with saying this patient who is on high-dose aspirin, NSAIDs, and possibly glucocorticoids presents with blank. Presents with epigastric pain. Even if they don't tell me aspirin or NSAIDs, expect aspirin and NSAIDs to be used in that patient. GI bleeding, iron deficiency anemia, in rheumatoid arthritis, think about the medication list. All right? If NSAIDs, aspirin, glucocorticoids don't work in rheumatoid arthritis, there are something known as the disease-modifying agents of rheumatic diseases. Disease-modifying agents of rheumatic diseases, DMARDs is the abbreviation. There used to be a long list that rheumatologists would pick between. It's now turned that long list has really been shortened to a shorter list, and always, or almost always, methotrexate is at the top of that list. There are drugs like gold, salts, penicillamine, azathioprine, many toxic drugs that are less effective than methotrexate. Methotrexate has really become the steroid-sparing agent and the disease-modifying agent of choice. All right? So let's talk for a moment about methotrexate because it does show up in many diseases. Methotrexate inhibits nucleic acid synthesis by being a dihydrofolate reductase inhibitor, so these patients will always need folate or they're going to get anemic. The organs that methotrexate can damage are the liver, where they can get fibrosis, and they can get an allergic reaction producing a hypersensitivity pneumonitis in the lung. So a patient who gets started on methotrexate for one of various diseases, it's used in RA, it's used in psoriasis, it's used as chemotherapy, it's used in Crohn's disease. If they tell you LFTs, think about methotrexate and liver fibrosis. If they tell you about a megaloblastic anemia and methotrexate's on the drug list, don't think about pernicious anemia. Think about methotrexate and you forgot to give the patient folate. So rheumatoid arthritis, symmetric, almost always involves the hands, but spares the DIP. Morning stiffness is very characteristic, and you can follow that as a parameter that the patient's getting better. They say, well, it used to take me till 11 o'clock till I could really get moving. Now with that new medication you gave me, typically aspirin or NSAIDs as first line, I'm getting moving by 10 o'clock and later 9 o'clock. When you see the USMLE released item, I kept treating that patient with aspirin or ibuprofen. And I say, patient comes, what do you want to do next? Okay, come back in 2 weeks. I didn't tell the patient come back in a day. It's too soon. Didn't tell the patient come back in a year. 2 weeks, 4 weeks, that sounds like a reasonable interval. The patient came back every 2 to 4 weeks, feeling slightly better, but still hands are involved. And I thought maybe I'm missing a diagnosis. I couldn't get this patient better. But that just goes to the fact that rheumatoid arthritis is a chronic disease, often tough to treat. And I kept giving the patient, I refused to give the patient steroids, because every time I saw she was getting better, I'd give her steroids. It took me about 3 months to get better. Maybe had I given her prednisone on the second visit, she would have gotten better right away, but again, at the risk of using steroids. The major risk I'm worried about in steroids, and you need to know about that whole long list: hypertension, diabetes, risk of infection, cataracts, glaucoma, oral thrush, hyperglycemia, hypokalemia, alkalosis. All of these are very important. The one I worry about most in rheumatoid arthritis, where there's already a disease of joint spaces, is osteoporosis. So in steroids and in rheumatoid arthritis, I'm particularly cautious to try to avoid it where I can. All right? And so I think when I did the USMLE released item on the CCS for rheumatoid arthritis, I don't think I would have lost points because I stuck to my guns and did not give steroids. If, on the other hand, I gave her NSAIDs, and every time she came back she had a higher fever, and she was developing joint destruction in front of my eyes, then I would have really needed to treat with steroids. Again, there are different ways to treat the patient. Inflammatory and constitutional symptoms in rheumatoid arthritis are common, and this patient, fever, maybe mild weight loss, anorexia, etc., are often the rule. The diagnosis, suspected based on the history and the physical. This question we figured out by about halfway through the history, the third or fourth sentence. Characteristic joint x-rays, joint space narrowing, and marginal erosions in that joint. And the serum rheumatoid factor is positive 90% of the time. If you have a great story and a great physical going for rheumatoid arthritis, and you appropriately order the rheumatoid factor, and it's negative, don't give up the diagnosis so quick. There's a small minority, 10% of patients, who have what's known as seronegative rheumatoid arthritis. That means they look like, smell like, x-ray-like rheumatoid arthritis, but there are a antibody, the rheumatoid factor antibody is negative. That's seronegative rheumatoid arthritis. They usually happen to follow a milder course. They usually have a high SED rate, the anemia of chronic disease. Can you think of any other reason, and we actually mentioned it, why these patients would develop anemia besides chronic disease? The answer is chronic NSAID and aspirin use, GI bleeding, typically gastric ulcers, duodenal ulcers. Treatment, NSAIDs or COX-2 inhibitors, and that's why I'm reiterating the treatment here, to give me an opportunity to talk about COX-2 inhibitors. COX, cyclooxygenase. All right, I already bored you earlier today with the cyclooxygenase and lipooxygenase pathways, where leukotrienes give you asthma symptoms, bronchoconstriction. In arthritis, cyclooxygenase pathway produces prostaglandins and prostacyclins. The prostaglandins in this situation, in a inflamed joint, causes more inflammation and mediates more pain. And the reason aspirin and NSAIDs are so effective is because you block the cyclooxygenase pathway, you don't get those prostaglandins produced locally. Now, prostaglandins in the joint is a bad thing, more inflammation, more pain. Turns out that prostaglandins in the stomach are a very good thing. The reason we don't all walk around with ulcers from this tremendous acidic fluid our stomach produces is because local gastric prostaglandins help protect the gastric mucosa. That gastric mucus bicarbonate layer in the stomach, that's thanks to your local prostaglandins. Those are prostaglandins in my body I don't want to inhibit. All right? And in fact, that's the mechanism whereby you get gastritis, gastric ulcers, duodenal ulcers, GI bleeding in people on NSAIDs. my cyclooxygenase is inhibited everywhere, not just in the joints. That's the mechanism for the benefit of NSAIDs, but an inhibition of prostaglandins in the stomach give me the GI toxicity. Now, the drug company said, wow, can't we design a drug that works to inhibit the specific prostaglandins that are turned on in situations of inflammation? And there's actually not only one COX cyclooxygenase pathway, there are two, COX-1 and COX-2. COX-1 pathway produces the prostaglandins that we need to have all the time, the prostaglandins that help the gastric mucosa, the prostaglandins that are important to maintain good renal blood flow. Think about it. One of the side effects of nonspecific NSAIDs, nonspecific COX inhibitors, is you get renal vasoconstriction, renal insufficiency. I need to have my background prostaglandins in my stomach, in my kidneys. How about if I could knock out only that COX-2 pathway that is inducible by inflammation? That's the COX-2 pathway. So the pharmacology industry looked for a drug that would block just the COX-2, and in the last few years they've come up with celecoxib, rofecoxib, which preferentially, not entirely, but preferentially block COX-2 and are about as effective as the nonspecific older NSAIDs like ibuprofen, naproxen, etc., and far less likely to cause the GI toxicity because I'm leaving COX-1 alone and I'm getting my background good prostaglandin production in my stomach and in my kidneys. So COX-2 inhibitors are going to be used more and more, not only for general pain of osteoarthritis, but also specifically for rheumatoid arthritis as well. Glucocorticoids, if NSAIDs or the more specific COX-2 inhibitors are not doing the trick, and DMARDs, methotrexate being the classical one, watch for liver toxicity, bone marrow suppression, give folate, and watch for a hypersensitivity pneumonitis as well. Don't forget about adjunctive therapy, joint protection in a joint that's inflamed. You put that joint to rest. Physical therapy and occupational therapy is important. It's not just something you say, okay, when we're done, we'll get some physical therapy. It's really a mainstay of therapy and improving that joint function. And these patients often have a accompanying depression and insomnia that makes them even more cranky during the day because they're not sleeping. They're depressed from an endogenous depression, depressed because they're sick and disabled. Remember to treat that as well. Okay, next case. 78-year-old African-American female comes to an unscheduled office visit complaining of left-sided abdominal pain for the past 24 hours. Let me make a point here at the end of this tape. Don't get fooled about where the patient is presenting. USMLE makes a big deal about you're going to have patients in the ER, you're going to have patients in your office for a scheduled visit, for an unscheduled visit. You're going to have patients at satellite clinics. Who cares? I could walk in with a dissection in my university health clinic and drop dead in front of your eyes, just like somebody could walk in with a headache that they've had for 30 seconds into an emergency room. It doesn't matter where the patient presents. You've got to figure out why the patient belongs there or someplace else. Now, this patient is coming for an unscheduled visit. That helps me not at all. She might be coming for an unscheduled visit because she has something terrible or because she's bored at home. All right? So, she's here for a left-sided abdominal pain for 24 hours, and she's 78 years old. Already in my mind, I should have a pretty short list of a differential diagnosis. All right? 24 hours in an older woman, I'm going to already start thinking this is more in the sort of acute emergent problem, certainly not stable and chronic. Pause me, play me. Okay? Patient 78 years old, African-American. African-American doesn't tilt me one way or the other in terms of a differential. I can't think of any disease that's more common in a 78-year-old black woman than a white woman. Left-sided pain for 24 hours. Patient had a similar episode approximately 3 months ago, which seemed to go away on its own. Yesterday, she noticed some mild abdominal pain on the left lower abdomen, which has steadily gotten worse over the course of the day in association with some low-grade fevers. All right, let's cut to the chase. What do we think this patient has? 78 years old, localized left lower quadrant pain. It's a short list. What's on that list? Inflammatory process in the left lower side of the abdomen. What lives in the left lower side of the abdomen? I'm a gastroenterologist. We are simple people. We are not too bright, else we wouldn't spend our day putting scopes up people's behind. All right? We got to think simply. When you got left lower quadrant pain, what do I think of? I think of what lives in the left lower quadrant. Sigmoid colon lives in the left lower quadrant. If she was 28 and she had more active ovaries and fallopian tubes, I think tubal ovarian abscess, pelvic inflammatory disease, that lives in the left lower quadrant. Not that many things live in the left lower quadrant. In a 78-year-old, the sigmoid colon is something that is a happening organ in a 78-year-old woman. All right? And it's hot. It got a fever on it. It got tenderness on it. What gets hot in the sigmoid colon in a 78-year-old woman, white or black? Diverticulitis. How about ischemic colitis? 78-year-old, her blood vessels ain't those of a 28-year-old. Could she have ischemic colitis? That's on my differential as well. Okay? That's my pretty short differential. Could she have an obstructing colon cancer and acute pain? Sure, but I want to get some more evidence that she got a colon cancer that's been growing for quite some time to cause an obstruction. Could she have an appendicitis with a really long tail and swings all the way over from the right to the left? Can that happen? Yes. The elderly are notorious for presenting with appendicitis in atypical ways. Okay? But at the top of my list, I got diverticulitis, ischemic colitis, a painful, hot, inflamed condition in the left lower quadrant. She denies nausea or vomiting. She denies a change in her bowel habits, any blood per rectum. She has an obstructing carcinoma. I would have liked to hear something over the last weeks or months in terms of a change in bowel habits, leaning towards more and more constipation, some rectal bleeding. She denies any change in her urinary habits or any weight loss. Again, weight loss, if this was a colon cancer that's obstructing, I would have expected some weight loss by now. Change in her urinary habits, well, if you got a big mass, it could press on the bladder, cause some urinary frequency. She doesn't have that. Her appetite is good until the last 24 hours. Let's put it that way. She doesn't have this anorexia of cancer. So again, diverticulitis, ischemic colitis. Now, between those two, I already got some clues that helps me distinguish. Does diverticulitis cause bleeding per rectum? No. Diverticulosis, when these diverticuli are not inflamed, an arteriole in the dome of a sigmoid tick can bleed. But in a diverticulitis, there's been a micro or a macro perforation, and there's an inflammatory process. And they can cause some pressure on the colon that you have a sensation that you got to go to the bathroom, but you go and nothing really happens. You can have a sensation of constipation for this last day or two. On the other hand, in an ischemic colitis, either rectal bleeding or diarrhea will almost always be there in association with the pain. And she has neither of those. So right now I'm leaning towards diverticulitis because there's no diarrhea, there's no rectal bleeding. Temperature, 101, pulse of 90, normal tensive. Okay? Ischemic colitis, can you have a fever with that? Yeah, you can. It's an ischemic itis, colitis. Any inflammatory process of the colon can produce a fever. Is this ulcerative colitis? No. Ulcerative colitis in a 78-year-old woman for the first time? Unlikely. Does it happen? Rarely. If it does happen, it will also present with some chronicity. Ulcerative colitis is a chronic inflammatory bowel disease, not a bowel disease that starts for 24 hours. Her heart and lungs, normal, abdomen soft, non-distended, left lower quadrant tenderness, mild rebound in that area, but no evidence of a diffuse peritonitis. So if this is if this is sigmoid diverticulitis, which I'm leading towards, and I'm given the guaiac negative, no masses, non-tender, no bleeding, I'm leaning more and more towards diverticulitis. Is this a massive perforation? No. She might have had a microperforation, might have an intramural abscess, an abscess in the wall of the colon, or maybe even a localized abscess, but she certainly doesn't have diffuse peritonitis. She didn't describe that by history, and she doesn't have it on physical. So right now, my strong leading contender, there were other cases, you heard me talk about that this case has to be this and nothing else. Here I'm about 90% confident this is diverticulitis. Can it still be an obstructing carcinoma? Just not likely. Can it be an ischemic colitis with just pain and tenderness without bloody diarrhea? Unlikely. So, my leading diagnosis here is diverticulitis. Fever, pain, possible mass in the area, which I didn't describe on the physical, but if you have a walled-off abscess, you have the question of a localized mass there, and constipation. Ischemic colitis, I want to see fever and pain, this patient has, but I also expect to see either the diarrhea or the bloody stools. Is the time frame correct for ischemic colitis? Can a patient develop ischemic colitis like that within 24 hours? The answer is they can. Can be fairly abrupt. An ischemic process anywhere could be fairly abrupt. Appendicitis, we discussed that appendicitis, although as you all know, occurs far more commonly in the right, that especially in the elderly, atypical presentations, particularly if it's a long appendix that's swung over, can cause symptoms on the left. But again, that's far less likely than diverticulitis. After all, a way to remember what diverticulitis presents like is to think of it as a left-sided appendicitis. Localized pain, fever, inflammatory mass, and something that might very well need an operation soon. Bowel obstruction. She might have this kind of pain, but if she has bowel obstruction that's severe enough to cause localized tenderness and rebound, by that point she already has some distension and obstruction. And I would expect to feel a possible mass, a history of chronic constipation, and a history of some, if not rectal bleeding, at least some guaiac-positive stools or an iron deficiency anemia, which so far we haven't been told about. I'll get a CBC. If it's diverticulitis, I'm going to expect a leukocytosis. I'm not going to have any particular reason for her to have anemia. On the other hand, I did a CBC on her, and her white count was, say, 10, 12,000, and she had an anemia with a hematocrit of 25, an MCV of 70. I say, whoa, hold on. I just gave you a whole long speech about what she probably has as diverticulitis and not cancer, but if she has a profound iron deficiency anemia, I might have to really back off and consider cancer again. All right? So CBC would be helpful in that distinction here. An SMA 12 in any of these cases is not really going to help us very much. Do we always do it when we do a CBC? Yes, but again, you're not going to lose points on CCS for ordering a serum chemistry here, but will help you distinguish between diverticulitis, ischemic colitis, and bowel obstruction from colon cancer? Not really. Abdominal x-ray, that would be helpful. It's not the ideal test. It's not going to show me anything pathognomonic for diverticulitis, but it's a simple, non-invasive test. Will tell me that the patient is not obstructed. And if the patient's had a severe episode of diverticulitis and has more than just a microperforation, I might also see some free air. That's always good to know. Right? Free air in the setting of diverticulitis, that patient is going to need surgery. Okay, so what did we have on our initial diagnostic workup? CBC, white blood cell count 15,000, consistent with the patient has an acute inflammatory process. Can I see this with ischemic colitis? Yeah, it's an inflammatory process. Can I see it in a patient with an acute bowel obstruction? Yes. Normal hemoglobin, again, bowel obstruction from cancer with a normal hemoglobin, unlikely. By the time they're obstructing, they're almost always anemic. Chemistry, normal. Abdominal x-ray shows some air-filled small bowel in the lower pelvis, no evidence of intestinal obstruction, no free air. Is this compatible with my diagnosis of diverticulitis? Yes. I have probably a local ileus of the small bowel in this area where there's inflammation. There's no evidence of obstruction. There's no pneumoperitoneum. Nothing has perforated in a significant way. Now, if I've come this far on a CCS, pretty straightforward CCS. How would I get here? You get the history, you get the physical. What do you order? I would order CBC. I'd order the abdominal x-ray. I got a lot of information from that physical exam of localized left lower quadrant tenderness, guaiac negative. CBC, basically, abdominal x-ray to make sure there's no obstruction, no free air, and then straight to a CAT scan. Binga, banga, boom. You got those three tests, you have your diagnosis of diverticulitis firmly established. You'll see either an intramural abscess or a localized abscess in the sigmoid colon, and you can begin treatment without any additional tests. If you say, wait, it's diverticulitis, this is a surgical disease, let me call a surgical consultation in CCS, they'll say, a surgical consultation has been called. That's it. You can't say, ask the surgeon what he or she thinks. Doesn't work like that. They'll say, the surgical consult is there and is awaiting further information. All right? Sometimes you'll be asked on CCS, why do you want the surgeon to come see your patient? In this case, I would say to make sure that the patient doesn't require emergent laparotomy. All right, you'll pick up a point there. I wouldn't waste my time with all that typing. I know the patient has diverticulitis. I know she doesn't have diffuse peritonitis, so I should know that the next step is going to be to treat the patient. How do I treat the patient? make the patient NPO, nothing by mouth, start some IV hydration, start some IV antibiotics. All right? Again, those three things, I've basically done everything for this patient, and very likely the question, the CCS computer will tell me, thank you for taking care of this patient, or if there's still time left, I might say, patient over the next 48 hours feels better, less tenderness, less fever, what do you do? I might switch the patient to oral antibiotics. Or they might say, despite giving the patient antibiotics, the patient continues to complain of pain. Now it's less localized, right side, less localized, more diffuse, higher fever, higher white blood cell count. What do you do next? Either repeat the CAT scan or even more directly, operate on the patient. All right? If I went and just started the patient IV antibiotics and I left out the NPO, I left out the IV hydration, I wouldn't lose big points. The key in diverticulitis is get the patient onto antibiotics because they do have a bowel infection in there. What antibiotics? Antibiotics that are effective against gram-negatives, enteric gram-negatives, as well as anaerobes. If the patient's getting worse, you're going to operate. And that's it for today. Thank you very much for your attention. Good luck on the exam.